Open.
Outspoken.
It's ophthalmology off the grid.
An honest look at controversial topics in the field. I'm Blake Williamson.
I'm Gary Wörtz.
Hello, and thanks for tuning in to a new episode of Ophthalmology Off the Grid. Doctors Blake Williamson and Gary Wörtz invite Dr. Nicole Fram to share her experience with a surgical horror story and her strategies for managing the case.
Welcome back to Ophthalmology Off the Grid. This is Dr. Gary Wörtz. I'm hanging out with my main man, Blake Williamson, the new deputy Blake Williamson. I want to hear a little bit more about that in a minute. But before we get into all that, I'm super excited to have really one of my best friends in ophthalmology to be on the program tonight. It's the one and only Dr. Nicole Fram. She's the managing partner at Advanced Vision Care in LA, and she's an adjunct associate professor at the Moran Eye Institute in Utah. And beyond that, she's a fantastic human being and one of the first millennial eye ones to watch back in 2013. So I think that Netta called it right when she nominated Nicole to be a future star. She is a star. And with that, Nicole, welcome to the podcast.
What's up?
What's up? Thank you so much for inviting me to be on this amazing podcast. I've been, kind of stalking you guys and watching you guys forever and listening. And I think what you're doing is fantastic. And, you always keep it fresh. And that's what I love about it. And you keep it real. And it's really an honor to be with both of you.
Well, thank you so much. We're big fans of your podcast, Quicksand Chronicles. Why don't you tell us a little bit about how that's going before we hear about Blake becoming a deputy?
Oh my God, I really want to hear that too. So basically over the pandemic, Liz, you and I started Quicksand Chronicles sponsored by ASCRS.
Who was the inspiration for that, if I might ask?
I mean, it was both of us. I mean, I was frustrated with everyone showing perfect cases. And I was like, this is not what's happening in my OR. And I think the psychology of getting through a challenging case and what you have to say to yourself and biofeedback and when to know how to stop and refer or calm yourself down and not make bad decisions was really on my mind. And so Liz brought it to the executive committee and it just happened. And we have had such a great time. Quicksand, Chronicles went for 2 seasons, and then we needed to put it behind a firewall because we didn't want any liability. And then we came up with Quicksand Chronicles Eureka moments. So those moments that like, hey, this happened, and it's such a quick thing to learn to speed your learning curve. And so the last 2 seasons, so season 3 and 4, have been about Eureka moments. And that's on YouTube. And so that's available for everyone to watch. This is our last season and we are moving towards, no, it's good. It's good. We're going to have a symposia at ASCRS.
Oh,
and
wonderful.
So the symposia is going to be 2 people, 3 people will submit videos. And then there'll be a panel of like 3 senior, 3 mid, and 3 young, like first 5 years. And we're going to go, there was a meeting in Park City that Alan Crandall started, and it was a great meeting because you'd show your video, and Quicksand came out of that. And like, stop the video and be like, what are you doing here? Why are you doing this? What are you thinking? And it's going to be raw and that kind of style to really help people learn how to get out of trouble. So it's still going on, but just as a symposia at ASCRS.
Excellent. Blake, I gotta hear about you becoming a deputy. This is big news in our world, and so I need you to tell us a little bit about this because I don't know if it's real. I don't know if it's I saw the badge.
Like a social media like stunt, or
is this a stunt or is this real?
No. You guys know that I'm real. I'm myself always, which is not always a good thing, but to my own fault. No, yeah. So in the state of Louisiana, great state of Louisiana, if you operate on the sheriff, you know, apparently you can reach out to be deputized, which is what I did. And Sheriff Weber's a friend of a friend, but we had to go up to the parish office and sign a bunch of documents and understand what it means, to be a deputy. But yeah, it's pretty crazy. I'm just waiting for my little light that I can put on my car so I can just run through traffic when I'm on the way to a Saints game or LSU game.
And
That's
you're
what.
gonna flash your badge, right?
That's
Oh, yeah.
right.
Flash that
I
badge.
switched all my credit cards and stuff to my new sheriff badge immediately. It's hard to even sit on it because I got so much stuff in that wallet with that big badge. And Nicole, my wife, is horrified, but I don't care.
You
I'm
a
just.
man bag. What about a Merce? We'll get you a Merce for it. What about your kids? Like,
Listen,
are
here,
they
this is Nicole. I'm going to fast forward this. I'm going to just tell you what's going to happen.
what?
It's going to go from the wallet to actually be pinned on his scrubs and pinned like right above his heart wherever he goes. So I think that's where the final resting place for the sheriff badge is gonna end up is
Don't
displayed prominently.
don't put it past me. I want to show the people what I
What do
got.
the
No doubt
kids
about
what
it.
do the kids think?
They love it.
Love it, right?
You're
My
crazy.
dad's a
I thought you were
deputy.
an eye doctor. You're a sheriff now. I'm like, I'm both.
Roscoe P. Coltrane. There you go. There you go. Well, let's get into the meat here. Nicole, we the season is called Horror Stories. It kind of follows a little bit of the Quicksand idea, where Blake and I said, we all like to talk about our stories where we save the day or talk about things we've learned and where we've really advanced our skill set or our field in some way. But it doesn't feel like we're telling the whole story, because I have had bad days in the OR. We all have. And when we have a bad day in the OR, sometimes we feel like we're the only ones or no one has had to deal with it. And I think talking about when things don't go perfectly helps us all realize that that's part of the job too. So in the spirit of kind of bringing ophthalmologists together and feeling like we're one big community of people who are just trying our best, that's what we're doing this season. And so I know you're a super busy surgeon. You tackle cases that probably nobody else in their right mind would be willing to tackle. And with that comes a huge responsibility. And we also know that when you're dealing with high acuity patients in complex situations, things don't always go to plan. So with that in mind, I think you said as we were chatting, but previously, that there's a couple of cases that kind of stuck out to you as we were discussing, having you on the show.
Yeah, thank you. The case that really I think about probably every day I'm in the OR is a case of a wonderful woman who was having a big problem. She had crystal lens perfectly positioned. They're about 5.5 millimeter optic and had really, really troublesome light arcs and starbursts and halos and things like that. And it came from oblique light, which was consistent with positive dysphotopsia. And it's from also the optic size as well as the square edge causing internal reflection. And so, there are creative solutions that you can do. Like my partner, Sam Mascade, who taught me everything about dysphotopsia. You can put a piggyback on and try and scatter the light, right? That's a great option. Wish I would have listened to my partner. Or you can try and take it out. And the whole reason why I never put in crystal lens in my career, because I didn't know how to take it out successfully. Like I saw a lot of problems with that. So that wasn't a lens of choice for me, even though I love silicone material. So I said to her, you know what? We did this study when we take out a lens and put, in your case, a larger diameter, so a 6 millimeter, even a 7 millimeter lens, people can do better. We can't change the square edge design because we don't have a fully rounded edge lens, right? So we had some success taking it out and putting, a larger optic in these crystal lens patients that were having trouble. And, there's a silicone lens, the Li61AO from Bausch & Lomb, which is kind of a dysphotopsia killer. There was also the CQ 2015 that was available from Star at the time. And so that was the lens choice. I said, let's change from silicone to Collamer, and let's put in a bigger optic for you. So I did her
Did
first
she have
eye.
large pupils? Just out of curiosity, did she have
did.
large?
They weren't that large though. They were, dilated to 5. It wasn't, that large. So it was 3 in the light and dilated to 5, but
It
it
was. You said it was
wasn't a
oblique.
myotic
Felt
pupil.
like it was
Yeah, it wasn't like
oblique.
she wasn't, it wasn't, an 8 mm pupil at night. That's a great question, right? That's why you're so smart. So, so what happened? I did the first eye, and silicone lenses can be really slippery, and the crystal lens has kind of these haptics that have these polyimide ends to it, and they really get fibrosed in the equator of the bag. And so, we're taught to amputate, the haptics, and then take the bulk of the optic out first, and it's slippery, so you got to get a really good grasp on it. And the first eye went great. I did everything that everybody told me to do. I amputated the haptics. They were still in the bag, but fibrosed. I took the optic out and I put a CQ in, and she's cured. And I was like, let's do it again. You got
Rinse
another
and
eye.
repeat.
I was like, yeah, I mean, and I'm feeling good. I was like, wow, everyone gave up and orphaned this patient because they said she was just crazy. And she just should adapt. And obviously we gave her bromonidine before surgery, and we gave her dilute pylo, and it just didn't do the trick for her. So we went to do the second eye, and I had been watching some videos, and they're like, why bother cutting a thick silicone lens? Why not just make a little scleral tunnel, and you can remove it in whole, and it's a lot easier to get out. So I was like, all right, I'm going to make a scleral tunnel this time, and I'll do a frown incision so that I won't get a lot of astigmatism. And yeah, let's try that. So I make a scleral tunnel, and I think possibly, I entered too prematurely. And when you're viscodissecting, I like to use dispersive viscoelastic. So I'm, viscodissecting and trying to get everything out of the bag, and it's working great, and I'm getting the haptics out. And all of a sudden, the half of the iris, half, comes out of the incision because I overinflated. I wasn't burping as I was, it's a blue-eyed patient and it's temporal. And I think, I mean, right now I could like start like I can feel it, what that feeling of what happened. And, you know, I had to just breathe and say, okay, I fixed this problem for other people. I know how to walk myself or walk some, what would I say to someone else? Like that's a strategy that I use, which is like, okay, this is happening to you. And I know I wanted to leave. I just wanted to leave. I wanted to cry, and you can't cry. There's no crying in surgery. And I wanted to leave. And I was like, what would you say to someone else? What if you had to go in the other room and help someone else? So, first question, is the eye hard or is the eye soft? Right? Anytime you have iris prolapse. So I actually had to go in. I kept trying to burp. You can't burp out of the main because half the iris is out of the main incision.
Right. You'll
So,
depigment. I mean, you'll lose
right.
pigment
It's
and
pigment. Yeah. And so is the eye hard, is the eye soft? So I'm burping at the incisions, and it's just not coming out. Like it's just not doing it. So I have to think, how do I get this viscoelastic out to change the gradient and make it low pressure in the eye and high pressure outside of the eye? And, when a lot of people just try and shove it back in with viscoelastic, it's more is going to come out. So I put in bimanual, and I just do IA with the iris hanging out of the eye. So at that point, it still didn't move, nothing's coming out. And so then
it seems like it seems like when this happens, you have to IA forever to get any, especially
right,
if it's dispersive.
right. Yeah. Dispersive
You have to
viscoelastic.
just, it feels like nothing is happening.
Nothing's moving, and so sometimes here's a trick there that I think I've only realized in the last few years, which is shocking. Sometimes you have to raise the irrigation a little bit, which is scary when the
It
iris,
seems
because
counterintuitive.
things aren't moving,
Right.
so to raise it just a little bit. And keeping it on continuous, you don't want to do in that when the iris is out, because you need to kind of pulse the foot pedal to get an idea of what's going on. So I start to see some move, that, things are moving, but the iris is still kind of stuck there, but at least I know the gradient is different. So the iris is still outside of the eye. So I'm in Quicksand. I am in a horror movie. Okay. And then I'm like, okay, well, I'm going to sweep from the side. So I go to sweep, and it was an aggressive sweep. And so I cause an iridodialysis. So not only do I have half the iris out of the eye becoming depigmented and knowing I'm going to have some transillumination defects, now I have a 3 clock hour iridodialysis. And I still have to get the lens. It's cut in it's cut in 3 pieces. Haptics are in the equator and the optic is in the center. I still have to get the lens out of the eye and then put the new lens in. And so I get
Can you take a moment right there? Do you just kind of pause? Like I find myself sometimes when things like this are happening, pausing and just like literally like looking up at the ceiling and being like silent for like 5 seconds, which freaks out my team a little bit.
I go full breathing, like heavy breathing, so there's, this Ujjayi breath in yoga where you like take a deep breath and it like comes out it's out your nose. It's called lion's breath. Okay. So I literally do that, and then I'll sit back and I'll like, I'll do a whole biofeedback situation. Um, and, and then I had the iris back in the eye. I know the iridodialysis is there. I put iris hooks at the base of my scleral tunnel to stabilize the iris because I knew I had to get things in and out of the eye. I take out the optic. I actually got the haptics out, which was joyous. And then I put in, the CQ 2015A, which is not available anymore. That was a Collamer lens. And that was rounded anteriorly. So that was another reason why I like to use that lens for positive dysphotopsia. I got it in the bag, and then I had to really like take a breath and be like, is it now? Am I in the right state of mind emotionally to fix this now? Should I come back in 6 weeks? What do I say to the patient? And somehow, I don't know how, I mustered up the skills to handle it on the spot.
Wow, it's amazing. Yeah, I would. There's no way I'd continue at this point. I mean,
Yeah.
number one, I just flat out don't have those skills. I would have to refer them to like, I don't. So I'd have to find somebody. Number two, like, I'm in a situation where I bet you there's like 30 people waiting, and I'm like, if I could be in here another 2 hours or
Right.
an hour, but if you have the skills, you can just attack it. That's amazing that you can do that. But it's okay to walk away if you don't have the skills. Like
It is, and that's the walk away moment. I mean, was I at my best? I don't know. What happened was I do these cases at the end, and I do it at the end so I know no one's
No
following.
pressure.
Right. So it takes the pressure off, and I schedule them for 2 hours, even if they take a half hour or an hour or whatever it is. So that's a lesson, that I learned from Sam Maskett, that you don't want to be looking at the clock when you're doing, because anything can happen, right, during these cases. And the whole concept of IOL exchange, we're putting in more and more premium lenses, diffractive optics. We're willing to take that chance on patients because at least in our practice, we say to them 1 to 3% won't like it. And if you don't like it, I'll take it out. And you
Exactly.
usually wait 3 months, but things can get pretty fibrosed in 3 months. So the skill set of understanding how to use a viscoelastic to get the anterior capsule off the IOL, how to get the haptics out of the equator of the bag, but the concept of whatever you put in, you have to let out, because if you don't, then you can have this horrific moment where the iris is going to follow the gradient outside of the eye. So I reset the team. I said, okay, pretend like we're doing a new case. That's what I said to everyone. Nobody look at the clock, and we know how to do this. And so we call for the sutures. We call for a moment to just get everything organized, redo the whole tray for iris suturing, to get ready for that, and different hooks and snares and bond hooks and things that I use. And we were able to repair it. So the story goes on though. So I repair it with tenoproline, and I do, you know, a mattress style hangback technique that I learned from Mike Snyder. And I thought I buried the knot, but I didn't bury the knot. So she's doing fine. And then all of a sudden the knot extrudes where the iridodialysis repair is. So now this wonderful woman who, let me explain how nice this woman is. She did fine. She did have some more dysphotopsia after I did that. But she would make me holiday cards so that I had holiday cards to give to patients, because she knew how busy I was, that she knew I wouldn't have the thank you notes to give to them. And so she made them for me, and she said, I'll pre-write them for you so that you have and this woman is the nicest woman in the world. So I did get lucky in terms of a human being for this to happen to. Um, but I then had to take her back and put a patch graft over it. So here I am again in this eye, you know, dealing with this. But I leaned into her and I saw her every week. And then I saw her every month. And then I saw her every 3 months. And then I see her every year now because she's fine. And, but it was really, and she didn't have, I mean, the main dysphotopsia went away, but she did have a few other things that happened with glare and kind of a whiteout from the transillumination defects. But, you know, this case was really a situation where I was trying a new technique. I wasn't using my, you know, gestalt of what I know in terms of letting viscoelastic out, and half the iris came out and I had to really kind of reboot. But I think Blake's point of stopping and coming back another day is also a really good point. And I've had to do that multiple times.
Yeah, that is, you know, that takes a lot of courage, because in my mind, I'm thinking, if I fix it now, the conversation can be, we got the lens, you know, got the lens exchanged, old lens is out, new lens is in. We had a few bumps in the road just because, you know, but we were able to kind of put the pieces back together. You know, we think it's going to be a major improvement, and you know, we'll just kind of monitor you. Versus the conversation of, you know, we got the lens exchanged, but we ran into some difficulties. I wasn't able to fix everything. We're gonna have to schedule you. We're gonna let you heal up and schedule you to come back. To me, that second conversation would have been very painful to have had. And so it doesn't mean it's not the right thing to do. I'm just saying psychologically, when you're in that moment, you're like, I just don't want to have to say,
I'm coming back.
want to have to tell her that we couldn't fix it all.
Let me jump in here, because I'm gonna say that depending on how you talk about it, it doesn't have to be painful. So the way I do it, if there's a situation, let's just say like a common situation where you break bag, or so you can't put a multifocal lens in like you planned. Instead, you put an Li61 in the sulcus, right? Um, you know, when I go in and have that conversation, you know, it would be reasonable to be like, you know, nervous about it, like, oh my God, we couldn't get that multifocal lens or whatever. But I do the exact opposite. I turned and said, oh my God, you wouldn't believe the anatomy in that eye. When I got in there and started like taking out that cataract, you know, that the bag that's supposed to hold that in there, it was not stable at all. It actually had a hole in it during the procedure. And I just don't think if I put that multifocal lens, I don't think it would be stable long term. I really don't. And I just don't think you'd be happy. Why would you pay that money if it's not going to be where it needs to be? The good news is I was able to get this lens exactly in the right spot. And I actually think with this lens, you're going to have more crisp vision, better contrast, better nighttime vision, better distance vision. You're not going to have that up close vision. I know that's a bummer. That's a big thing, but that's why God gave us the other eye, right? So I think we're going to nail that. So I kind of phrase it like that. Like I saw some, which is totally true, but it's a version of the truth that makes, you know, that makes the most sense to say there were some anatomical things that I encountered. I was worried about you, but I was able to save the day and get an even better lens in some ways, and in a more a safer spot. So I think you can kind of phrase it like that, Gary, you know?
No. I, you know, there's a version of that I use as well, you know, in terms of like explaining the problem in a way that a patient can understand and is palatable, but is still true, but does not alarm them. But it would be different though if you said I had to leave you a phakic, right? You know, and
No,
sometimes
no,
you have to do that too.
but those are the heroic moments, I think, as a surgeon, is when you know, forget about skill set. Like, assume we all have the same skill set. The whole thing about psychologically where you are in that case, where you are in your day, where you are in your life, I think matters. And we're supposed to go in and be robots and not have any emotion, you know, when we're operating. That we're not supposed to bring it into the OR, right? But inevitably, when you're in a situation like this, the emotions come up, and we're not taught to manage those, right? We're taught to be like, suck it up, don't worry about it, put it in another compartment because you got to move on to the next case. And that is really functional. That is appropriate. You can't break capsule on one case and then cry for a half hour and then not finish the rest of your lineup. You have to, right?
Right.
So
Yeah.
I think what we're trained to do this, but I think what we're not trained to do, or what I wasn't trained to do, I can only speak for myself, is when to stop and when to really realize when you can't be at your best. And that's what this case really was showing me. I mean, I was okay moving forward because I was like, I wasn't worried about what I was going to tell her. I was like, I did that mantra in my head. I fix this for other people. I know how to do this. I have to separate this and pretend I'm fixing this for someone else. And that's how I did it, right? That's how I got through it. But there have been times where I try and do a Yamani and it's like it's tilted and it's not centered, and I'm like, I can't handle this. I'm not trying to do another one. I'm going to do a sutured MX60 because I know it goes where I want it. It just happened last week. Like, I was like, I can't try to do another Yamani on this small little eyeball that's sunken in with a giant nose. Like, I can't try it again. I have to do my fastball on this. And, you know, Yamani's everybody's fastball, but sometimes it just doesn't center or it's tilted or whatever happens. And so that's what that I think these horror stories need to teach us, is when to really understand how to tap into where you are emotionally and what you're able to do in that moment.
Yeah. So when you're describing this case, I've had in the past month, I've had 3 eyes with Verisize,
Mhm.
claw
Yeah.
ACIOL, or, you know,
Fun.
phakic IOLs, and kind of scheduled just in the middle of my day. And for anyone who's not done these, Blake, have you done these before, taking out a Verisize? Now, if if it's an ICL, that's easy. I mean, basically you just pull the ICL out. It's a complete piece of cake. But the Verisize, it requires a 6 millimeter incision. You can't cut it. It's PMMA. So you have to do a 6 millimeter incision, and then you also have to do the cataract surgery. And so I have done this 3 different ways, and I have yet to find a way that I like doing it. But my most recent way, because the first time I did it, I made a large incision, took out the Verisize lens, sutured the sides of the incision, so it basically kind of made it a pseudo
Mhm.
3 millimeter
So did you do
incision.
a scleral tunnel or did you
I
do
did.
the
Yeah, I
cornea?
did I
Okay.
did a scleral tunnel.
Mhm.
Or it wasn't probably a full scleral tunnel, but it definitely had, I probably had a millimeter to 1.5 millimeters of sclera before the limbus. So it was maybe not, it could have been a little bit longer, but it definitely had scleral component to the incision. Sutured it, and just, it was leaky. I mean, I did the phaco, but the fluidics just never felt right to me. I was able to make it, but it just kind of felt like, okay, I don't really love this. So the next time I did it, I decided to make my normal phaco incision, but like with a scleral base to it. And I just dislodged it and put it in the angle and took the cataract out with the lens just kind of in the angle. But then when I went to IA, the thing started moving around too much. So then I had to switch and take the Verisize out and then do IA, and it was kind of the same thing. So next time I'm like, okay, I'm going to sit superiorly. I'm going to do a 6 millimeter incision superiorly, scleral tunnel. I'm going to just take it out superiorly, suture it up, and then I'm going to move temporally
That's
and
the way to
do.
do it. That's what
Okay.
I do.
Okay. Well, so I'm a slow
Yeah.
learner, but I am learning.
No, but
Okay.
Bill Wiley does the phaco underneath it while it's still attached. I'm like, how, what,
That's
so
so
that's
the
a
rules
baller
of
move. I can't do that, so,
those are
but
Bill Wiley rules. Okay. They
yeah,
don't apply to all.
yeah.
Okay.
But
But
I think I think that, that trial and error, I took out the crystal lens one way and then I was like, hey, I'm going to try this other way. And that wasn't the right way for me. But that was because I overinflated. It probably was a fine way to take it out.
well,
Um,
the problem was when I went through Superior, apparently the person who had done the Verisize originally had gone Superior and made a really short entry. And so when my incision dissected that, and we basically had almost like no corneal shelf. So as I'm taking this out, guess what happens? About half the iris comes out. So as you're telling your story, I'm reminded of my very recent story of taking the Verisize out with like half of the iris out. And I've got it basically, once the Verisize is out, I'm basically taking corneal bite, going over the iris, then trying to pick up the sclera. And I got it closed. It took me 3 infinity sutures, so 3 figure of 8 sutures, got it closed and got it watertight. And I got it done. But it's like, you just have to remember that if you're ever doing a scleral tunnel, it's so important not to enter too soon, because as soon as you do, that iris wants to come out at the base. And once you start getting iris coming out from the root, it is not fun.
This reminds me to, if I have a Verisize to refer that to you if I need to get an explanation.
Please, I would love another shot at it. I would just
yeah,
love,
just to get
maybe
it
the
right.
fourth time I'll really love
But
it.
I mean, something as simple as scleral tunnel. I mean, so many people are not learning this, in residency, unless they do international work, they won't know small incision. Yeah, but the key there, that I learned from, my international colleagues is that when you're making your scleral tunnel, even if you're too close to the limbus, as long as there's equidistance on the sclera and the cornea, where you dissect that, then you won't have that issue as likely to happen. So if you're 1.5 behind, the limbus, be 1.5 in
Into the cornea.
morning, you know. But yeah, I mean, all these things are, as I say, very humbling. And I think that it's really important to treat each case and learn from other people's, quicksand moments or horror story moments so that you can skip that step.
And embrace the journey. I mean, I know we only have one minute left here, but just real quick, I do have to shout out, Nicole, because at the recent Business of Refractive course for Ascus put on and Vance and them put on, and I guess where we were in Dallas. Uh, she said something that I thought was unassuming but profound, and she probably wasn't meant for it to be, but it was to me. She said that we all accept that there's a journey before cataract surgery. What we need to understand is that sometimes there's a journey after cataract surgery. And I think that's like a parting message for this podcast is like everyone listening to this and understands there's a journey before cataract surgery. There's all these diagnostics and tests and consultations and lens counselors and billing department, on and on and on and on. And we think we just do our little quick case and that's it. And we're done. And luckily that's true, like 99% of the time, 95% of the time, whatever. But sometimes it's not true. And so I think that you really separate yourself when you embrace that, okay, we're going to have a journey. And just this week, like yesterday is my big cataract day, I explanted a symphony for an Odyssey because the patient wanted more near vision. I explanted an Odyssey because the patient was still having issues with dysphotopsia 4 months post-op, and just put in an LS61 and gave them their readers, no big deal. And I rotated 2 toric lenses that had rotated off axis. And then today, my LASIK day, I actually had a flap lift and a retreat on a primary LASIK, and I had a hyperopic +1 on a presbyopic correcting IOL. So I never, ever, ever would have that in my first several years in practice because I would just try to explain it away, dry it, conversation away, neuroadaptation, maybe in a year, blah, blah, blah. And I've just more and more I've embraced that no, there's an issue. you know how to fix it, embrace that. The other 95% of people don't need this. So that, and now I look at it, it's almost kind of fun. It's almost like when they come in like, I'm like, okay, let's put this puzzle back together. You have to have that mindset, or else you're not gonna be a great refractive surgeon.
But we don't, I love that because we don't teach that. And so now we are, we're teaching how to get out of trouble. We're teaching how to lean into your patient. And what you just talked about is just exemplifies the commitment you have to your patient. You have a commitment to them. When you put in a lens, when you decide to do an exchange, whatever you do with them, you are now committed to that patient to help them through their journey. And it takes a while to get the confidence to be able to do that and not, pull away when they're upset, and to lean into them and be like, we are going to work this out together. So kudos on this
Took me about
podcast.
about 6 years. Took me about 6 years to get that.
That's fast.
That's faster than most. But honestly, what you said, Blake, is 100% true. Until you get the confidence to say to a patient, look them in the eyes, and I say almost the exact same thing as Nicole is like, I say 1 to 2% of patients can't tolerate a multifocal lens. We will not know if you're in that 1 to 2% until we put the lens in. Actually saw a patient today. I had about a 30-minute consultation with this 46-year-old who is a +7, -4 in one eye, and a +8, -5 in the other eye. He's 47 years old and wants a refractive lens exchange. Amblyopic of 20/40 in his worst eye and 20/20 correctable in his good eye, but he's not yet presbyopic. And I said to him, I said, okay, what is it that you're really bothered by with your vision right now? Because I want to make sure we're really on the same page here. He goes, well, I just think, it's kind of annoying to have to wear contact lenses, and I travel a lot. I don't like the way I look in glasses. But I go, but with your contacts, you see pretty well. All right. He goes, yeah, I see great with them, but it's just like annoying. And, my eyes get tired sometimes. And I go, are you wearing reading glasses at all? He's like, no. I'm like, okay. I said, listen, the options I'm going to have for you today, or maybe a year or two from now, are about the same, but the value proposition is going to be very different once you start wearing reading glasses. And I said, I can fix you to the extent that it's feasible to fix you, but I don't want to operate on you until you recognize that you have more deficits and that you're right on the razor's edge of that. But I really spent a long time like digging in, because usually, a +7 or +8 with 4 or 5 diopters of astigmatism, he's seeing 20/25 in his contacts with both eyes. And I just said, you know what? I don't think this is the right moment for you. So for me, that was my kind of walk away, like, all right, I'm going to stop this train before it starts. He was very thankful. He was actually like, I actually really appreciate you saying this, because, I want your perspective. That's why I came to you. And so sometimes, like you said, with the journey, Blake, it's like, even before surgery, understanding, am I getting myself into a situation that's going to be hard to get, back out of, and setting yourself up for success is as important as anything else. So anyways.
Well, I'll leave you with one thing that Sam Askett probably stole from someone else, which is, experience is what you get when you don't get what you want. It's a good one.
That is a good one. Experience is what you get when you don't get what you want.
I'll find out who said it the first time, but he and then another one he says is, we think practice makes perfect. It doesn't. Practice makes permanent. So the more you take on these cases, and the more you are in situations where you can realize what to do, you will permanently be able to handle that and address it and apply it to the next case.
You add a new program to your operating system. I love it. It's perfect.
We gotta end it right there. That's strong. I love it. Thank you, Nicole.
You're welcome. Thank you, guys.
Okay. Until next time, this has been Ophthalmology Off the Grid with Blake and Gary. We'll see you soon. Bye.
Thank you once again for listening to Ophthalmology Off the Grid. And thank you to our guest, Dr. Nicole Fram, for sharing her experience with us. Tune in next time.